All right, valvular heart defects. So what is it? It's cardiovascular damage from malfunctioning heart valve. Can be manifest as mitral valve, aortic valve, or a tricuspid valve defect. And mitral valve prolapse is the most frequently occurring valvular heart defect. It is a prolapse, which means that the valve is kind of flopping backwards into the left atrium. And stenosis may develop, which is that backflow of blood from an incomplete valvular closure. And it's oftentimes diagnosed through an echocardiogram. Okay, I want to make sure that I have I set up all my notes here. So valvular malfunction can occur by stenosis, which is an incomplete opening of the valve, or regurgitation, which is a backflow of blood through the valve because of an incomplete closure. Left ventricle hypertrophies, left atrium hypertrophy could lead to congestive heart failure. Most patients with heart murmurs related to mitral valve prolapse require no alteration in dental hygiene care. We used to pre-med everybody who had a heart murmur. We do not do that anymore. Mitral valve prolapse does not require pre-medication. Although a thorough patient history can identify valvular heart defects that require modification, for example, when valves have been replaced. So kind of what we were talking a little bit about before, if they have a artificial valve, or if they still have a defect, if there's something more complicated going on and their cardiologist wants them to have pre-med. So then we might have to reach out and find out what their doctor says. And again, the echocardiogram or echocardiography is an ultrasonic wave to detect the heart size, the valvular function, and other structural deformities. So risk factors commonly associated with rheumatic fever, we'll talk about that in the last section. It could be congenital, it could be a congenital heart defect, or it could develop after infective endocarditis. So if they have infective endocarditis, it could damage the heart valve. Some patients with valvular heart defect take anticoagulant medications depending on the underlying cardiac condition that caused the defect. So we have to be aware of medications that they could be on. Corrective surgery is performed for most valvular heart defects. If the valve cannot be repaired, in most cases, prosthetic valves are available to replace a defective valve. For individuals with mitral valve prolapse, surgical treatment is not usually necessary unless it's aimed at alleviating symptoms such as like palpitations, or if there's chest pain or this nervous feeling, fluttering, shortness of breath, dizziness. Medications are given to control chest pains, slow the heart rate, reduce palpitations, and lower anxiety. So we have to do a little bit of detective work with our patients. If it's just a straight murmur, that's pretty simple and it doesn't really require anything. But if there's more going on, if they've had surgery on the defect and they have a valve replaced, that's more serious, and we have to see about medications or pre-medication. So for their dental hygiene care, it's important that they have good oral hygiene, good daily care. A patient who has had a prosthetic valve requires pre-med prior to dental hygiene treatment. So we have to know whether or not they've had a valve replacement. And then we want to encourage regular maintenance. If they have good control of their oral hygiene, good control of their biofilm, this is going to reduce their risk for self-induced bacteremia or their increased risk of infective endocarditis. So it's important that we educate our patients on their importance of their good oral hygiene. So some guidelines, appointment guidelines, is the patient taking anticoagulant, and examples of that could be heparin, warfarin, or Coumadin, and then indapamide. Oh my gosh, derivatives, whatever this word is, derivatives. So we want to know normal prothrombin time. A normal prothrombin time is somewhere between 11 and 14 seconds, but overall it must be less than 20 the day of dental hygiene care. And so we could patient might know it. They might know their prothrombin time or their clotting factor, their clotting time, or we may have to call their physician. So for laboratory consistency, there is something called the internal, I didn't put a space there. There's supposed to be a space right there. The internal normalization ratio, or INR, and a normal INR is 1.5, and treatment can be performed between a 2 and 3, but we don't want the INR to be above 3 if we're going to do something like scaling and root planing. So we have to consult their doctor. If somebody is on anticoagulant, we want to find out that information, talk to them about our procedure and what we plan to do, and then we want to obviously scale one area at a time. So we're going to pick the least inflamed area to begin and see how the blood clotting is. So we're going to pick the least inflamed quadrant and start scaling there and kind of see how they're doing with their clotting. Periodically check the clotting time, see if it takes a long time for the clotting to start and for the bleeding to slow down or stop. And then emphasizing good daily oral hygiene. The less inflammation, the better chances that they're not going to have a bleeding problem, because things won't be so inflamed and so there won't be as much blood. So let's talk about rheumatic heart disease. So what is rheumatic heart disease? It's a cardiac manifestation of rheumatic fever. So there's a possibility of having heart damage when somebody has rheumatic fever. And the valvular damage may lead to a heart murmur, which just is that turbulent flow of blood through the valve that hasn't closed. And somebody could experience permanent valvular damage, and they could end up having surgery. So it could lead to some of what we talked about just a minute ago with the valvular heart damage, or it could be just a benign murmur. Whenever we see rheumatic fever on a medical history, that is basically our red flag to ask them further questions, because it may or may not be a big deal. But if somebody, what are the risk factors of rheumatic heart disease? So the risk factors would be somebody who had strep throat, and then they may have developed rheumatic fever within 2 to 3 weeks after their initial infection. So the risk factors are having had rheumatic fever. A history of rheumatic fever may indicate valvular defect. Most destructive effect of rheumatic fever is damage to the valves are susceptible to infection that may lead to infective endocarditis. So like I said, it could be something very small and benign that's really not a big deal, or it could be a major valvular damage that puts them at risk for infective endocarditis. So we have to kind of weed this out and know what we're dealing with when the patient comes in. So just because a person had a history of rheumatic heart disease, or a history of rheumatic fever for that matter, does not automatically mean they are at a high risk or a higher risk, and that they don't necessarily need pre-med. However, like I stated, we need to discern that and find that out by asking the right questions about their history. And the patient will know, or they should know anyways. So having a history of rheumatic heart disease does not necessarily mean the patient requires prophylactic antibiotic premedication. But it is important that they have meticulous interdental cleaning and biofilm removal, establish good oral hygiene habits to prevent self-induced bacteremia. So if they have heart damage, finding out the severity. Is it just a mild murmur, or is it a significant defect that has required surgery or something like that? Okay, so appointment guidelines: frequent continued care intervals to maintain good oral health, client-centered home care instructions to maintain optimal oral health practices, pre-procedural antimicrobial rinses before tissue manipulation to reduce severity of bacteremia. pretty standard, nothing really out of the ordinary there. Infective endocarditis. What is it? So infective endocarditis is an infection of the endocardium, the heart valves, the cardiac prosthesis resulting from an accumulation of microbes and microbial invasion. It's caused by bacteremia, staph, and strep mostly. However, there is yeast and fungus and viruses that have been implicated, so that's why they refer to it as infective, not just bacterial endocarditis. Risk factors would be somebody who has had previous endocarditis in the past, someone who has an artificial heart valve, serious congenital heart condition, a heart transplant, who's developed valve problems. So we have to be aware of people who have had these things. If someone has had previous endocarditis, when we do our invasive dental or dental hygiene therapy, we want to be aware of those patients with those previous conditions. Now, what is invasive dental hygiene therapy? Invasive dental hygiene therapy is defined as a procedure that involves manipulating the oral soft tissues, or if it's a dental procedure, manipulation of the periapical area of the teeth or oral mucosa. So basically anything that is going to cause like bleeding and getting in there and introducing bacteria into the bloodstream. Cut anything, especially that would cause like cutting or something like that. But anything that's has a direct relation to blood flow. So dental hygiene care, identify your high-risk individuals via the health history, proper protocol for antibiotic premedication if they require it, pre-procedural rinse to cut down on the bacteria in the mouth, prevent unnecessary trauma. So when you are doing your scaling and root planing, you have to be thorough, but being also very aware of not causing undue trauma. Help client maintain their optimum oral health, so the least amount of inflammation will improve all of these conditions if they have good brushing and flossing and interdental care, and encourage regular continued care so they can stay on top of these conditions and minimize the amount of inflammation in their mouth. So the disease process of endocarditis, there's acute bacterial endocarditis. This is a severe infection with a rapid course of action, usually caused by pathogenic microorganisms. It is, oh my word, microorganisms, strep and staph, and it is capable of producing widespread disease. Then there's subacute bacterial endocarditis. This is the one that oftentimes is seen a little bit more related to dental procedures. It's slow-moving infection with non-specific clinical features. Affected persons usually exhibits continuous low-grade fever, marked weakness, fatigue, weight loss, and joint pain. Dental and dental hygiene procedures that manipulate soft tissue may be responsible for SBE, or subacute bacterial endocarditis, in patients with previous heart conditions that make them more susceptible. So as endocarditis progresses, the circulating microorganisms attach to that damaged valve or other susceptible area. That's what led them to worry about joints. They worried that artificial joints were susceptible areas. So that's where there's that kind of gray area. It's not recommended to have pre-med with artificial joints anymore, but that is kind of what the theory was in the beginning, and that's why it used to be something that was just automatic if you had a joint replacement. The invasion can result in cardiac failure, so it's can be a very big deal. People can be very sick from endocarditis, bacterial endocarditis, and infective endocarditis. So appointment guidelines identify your high-risk individuals again through the health history and patient questioning. Ensure that the patient, if they are supposed to, that they've taken their prescribed antibiotic 1 hour before your procedure. You want to get that antibiotic level high in the body to be ready to fight any infection, bacteria, and other yeasts or, fungus or whatever that's floating around in the bloodstream. Have the patient use the pre-procedural rinse, prevent unnecessary trauma, help each client as a co-therapist to maintain optimal oral health and daily oral biofilm control. This will help them minimize self-induced bacteremias. Encourage patient to schedule their continued care as needed. Another thing, if a patient is a pre-med patient and they take pre-medication for whatever it's required for, it's important that we spread out their visits if they're in a multi-treatment treatment plan for a scaling and root planing. So we want at least 9 days to 2 weeks between prophylactic antibiotic pre-medications, if multiple appointments are needed. So we want to spread out. Usually we'll do half the mouth, and then 2 weeks later we'll do the other half the mouth. Pay attention to drug allergies if a patient is allergic to penicillin. So we want to be sure that they're not taking, especially if you keep pre-med in the office, you don't want to just hand them any old pre-med. You want to make sure that they're not allergic to it. Okay. This video is going to be a little bit, let's stop here and then we'll do one last video.